We finally made it. We finally made it. 5,000 subscribers on the channel. And I really wanted to do something special for you guys. So I decided to actually switch up my style of teaching and try something new. If you guys really love this method of teaching that I'm about to introduce on the channel, please subscribe to the channel. Hit the bell notification icon to receive a notification of such amazing content every time I post. Drop a like, drop a comment, grab a piece of paper, and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at a very important topic, which is going to be diabetic ketoacidosis management in children. I know you're saying that, but I've already done a video on this. This is going to be pretty much focused for my final year students, so it's not going to have so much detail as it had in the previous DKA video that I did on the channel. Moreover, this one is going to be a very practical one. So without further ado, let me switch now to my Blackboard because we're going to be having a Blackboard lecture. So today we're going to be focusing pretty much on DKA or diabetic ketoacidosis. Now remember that in DKA you're going to be having this uncontrolled catabolism that's going to be associated with, number one, you're going to be having an insulin deficiency. So you're going to have an insulin deficiency that's going to be, of course, being triggered by a trigger. It could be an infection, it could be stress, it could be anything that is triggering absolute insulin deficiency. Now this absolute insulin deficiency is going to be, of course, in combination with hyperglycemia. So you're going to be having hyperglycemia. So now remember that with this hyperglycemia, I don't know how I spelled hyperglycemia here. With this hyperglycemia, you're going to be having a random blood sugar that's going to be greater than 11 millimoles. Okay, so you're going to be having certain characteristic symptoms. You're going to be having your blood sugar that is greater than 11 millimoles. In addition to this, what else are you going to be having for you to say that this person is going to be having DKA? Number two, you're going to be having osmosis, or rather osmotic diuresis. Okay, osmotic diuresis. This would be SIS, diuresis. So it means this person may be actually coming in with features of dehydration. So this can actually lead to dehydration. Then the third thing that you're going to be having is that this person is, of course, going to be dehydrated. So you're going to be having features of dehydration. Now keep in mind that dehydration at the level of DKA more or less is going to present as severe dehydration. So most of the patients are going to be coming in with severe dehydration. And remember when we talked about dehydration, the different types of dehydration, we have no dehydration, some dehydration, and severe dehydration. And in severe dehydration, the assumption is that someone has actually lost more than 10% of their body weight. Okay, but keep in mind that this 10% body weight is often overestimated, and especially in areas like our country where it's actually a third world country and the prevalence of malnutrition is higher, we're actually going to be using a percentage of about 6.5 to about 8.5%. So keep this in mind that we're going to be using 6.5 to about 8.5% to calculate the percentage loss or the deficit. We'll come to that in details very shortly. The fourth thing that you're going to be having with these patients is that you're going to be having ketonemia. So you're going to be having ketonemia. So this is pretty much ketones that are present inside the blood. And these are going to be greater than a concentration of 3 millimoles per liter. Then the fifth thing is that you're going to be also having acidemia. So, or you can say acidosis. So remember that with acidemia, the pH of the blood, so your blood pH is going to be less than 7.3. Remember that the normal pH is 7.35 to 7.45. But in this case, in patients that actually have DKA, the pH is going to be acidotic. And then eventually this ketonemia is eventually going to be leading to these ketones being excreted in urine. We call this as a significant ketonuria. So you're going to be having significant ketonuria. And this significant ketonuria is going to be graded, meaning that if someone has ketones that are greater than 2 plus or more ketones in the urine, then you say that this person has DKA. Now, how exactly are we going to treat this patient that has DKA? Now, remember that this is an emergency. So the first thing that you're going to be doing on your treatment is that you're going to be looking at your ABCs. So number one, we're going to be doing our ABCs. For every emergency, we're going to be focusing pretty much on this. So we're going to begin with our airway, which is of course A. Now remember that whenever you are assessing the airway, ensure that it's patent. If the patient is comatose, you pretty much want to insert an airway. So we want to insert an airway to ensure that our airway is secure. If they have recently vomited, you want to also insert an NGT, aspirate from the NGT and leave it open to drain. So you're going to be, of course, putting an NGT in this patient, especially those that are comatose and especially those that have vomited. So if there have been decrease in loss of consciousness or they have been vomiting, that's when you want to actually insert an NGT. Then the second thing that we're going to be focusing on is pretty much the breathing. So in this case, you want to give them oxygen. So we're going to be giving them 100% oxygen. And this is whenever it's indicated. You may actually bag and mask ventilation. If this person becomes apneic, you may actually need to start to resuscitate them. And remember, our aim here is that we want to keep our saturations optimal, so we want to keep them greater than 92%. Then the C that we're going to be coming to is of course our circulation. Now remember that here in DKA patients, you're going to be wanting to insert 2 large bore IV cannulas. So you're on a 2 large bore IV cannulae. And of course, one of these is going to be for the administration of the fluids. The other one is going to be for the administration of the insulin. Now, at this moment, you can actually use this IV access here to be the moment where you're actually going to be collecting your blood samples. Then we come to D, which is of course our disability. Now, here you're going to be assessing the level of dehydration. So we're going to be assessing the dehydration at this stage, and we're going to be grading the dehydration. Remember that most of the times the grade is going to be based on either your BC, not the grade of dehydration, but the dehydration is going to be either moderate or severe. But in most cases, like I said, we're going to be having severe dehydration in the case of diabetic ketoacidosis. Now, after you've assessed the level of dehydration, you also want to actually look at your RBS. Remember that your RBS is more or less going to be greater than 11. Then you also want to assess your level of consciousness. So you assess your level of consciousness. Now this can be done in 2 ways. In children that are quite young, you can use your Blantyre Coma Scale. In children that are much older, you can use your GCS or your Glasgow Coma Scale. I'll actually go into details of the Glasgow Coma Scale in another video and not in this video. And remember that these patients that are DKA patients may actually pretty much come in shock. So they may come in with, of course, features of tachycardia. There's going to be poor capillary refill time. There's going to be, of course, hypotension. So you have these 3 things that you're looking for. Capillary refill time. Remember that the normal capillary refill time should be less than 3 seconds. The second thing is that you're going to have hypotension, which is going to be pretty much another indicator that this person is in shock. Then of course you're going to be having tachycardia. So once you have these things on your patient, it will mean that this patient is obviously in shock. You're going to have to manage the shock. And how exactly are we going to manage the shock? We're going to be giving our 20 mils per kg body weight, and this is going to be of normal saline. And of course this is given as quickly as possible. The maximum for this that you can give is 60 mils per kg, 60 mils per kg. So now let me give you a practical example. Suppose we get a patient that is weighing 25 kg and they come in with DKA and they come in shock. So how exactly are we going to manage this patient? So we say our 25 kg, we multiply that by 20 so that we see how much fluid are we going to give this person as a bolus. So this comes down to about 500 mils as a bolus. But then if we calculate the maximum of this 60 mils multiplied by 25, our maximum should be 1,500. So if this person is still in shock regardless of you running this 500 mils to run fast, and they're still in shock, then we're obviously going to be continuing until we reach a maximum of 1,500. You should never exceed 1,500. Then the other thing that is going to be there on our management is, of course, we want to confirm. This is point number 5. We want to confirm the diagnosis. Now, remember, with confirming the diagnosis, like I said, you're going to be looking for certain characteristic features. So on your history, you're going to be asking certain things, which are very important questions. Of course, there will be a history of diabetes. If there is no history of diabetes, this may be the first time that this child is actually presenting with diabetes. Clinically, you're going to be looking for signs of dehydration, signs and symptoms of dehydration. So you have those different signs and symptoms of dehydration: the depressed level of consciousness, the sunken eyes, the depressed anterior front. Now, in the very, very young children, especially when I remember when I was actually in the COVID department, we actually was at one point, there was a child that I remember that actually had a very high blood glucose level, had some ketones, and actually was managed in a similar way to this child actually having DKA. So you actually want to look out for this history and, of course, your physical examination. So your history and your physical examination. Now, your history and your physical examination are pretty much going to be picking out these signs of dehydration that we have over there. Then the other thing that you're going to be doing, so on the confirmation of the diagnosis, the history and physical examination, that's pretty much going to be your clinical assessment of this patient. And in addition to this, there's going to be some biochemistry that is actually needed. So you're going to have to perform some biochemistry. Now, remember that here you're going to be having a very high random blood glucose, and this is greater than 11 millimoles. The other thing that you're going to be having is that you're going to be having these ketones that are increased, greater than 3 millimoles in the blood or greater than 2 plus in the urine. When you check the urine, you're also going to be having some glycosuria, which is pretty much urine that is present or glucose that is present in the urine. You're also going to be having the ketonuria. So once you have these things and you're able to actually prove these things, then this patient is actually a candidate for the diagnosis of DKA. And remember, in your physical examination, do not forget also to assess the level of consciousness. So you're going to be also assessing the Glasgow Coma Scale. You're also going to be using your Blantyre Coma Scale depending on the age of the child. And another important thing to actually do, just as a side note, is if you actually have an ECG machine, you can actually connect this patient to the ECG machine and you can actually continuously monitor them with the ECG. So now, how exactly do we manage these patients? So we come now to the management. Since we have now looked at the preliminaries that you're going to be doing, if this person is in shock, we pretty much are going to be bolusing them with our 20 mils per kg. But now, what if you've gotten them out of the shock and you want to manage them as a case of DKA? So in the management of the condition, there's a mnemonic that I like to use. So you can actually use the mnemonic FIPA, or you can use the mnemonic CIPA, depending on whatever you want. So the F is standing for fluids, the I is standing for insulin, the P is for potassium, the A is for antibiotics, and of course the S is for solutions, the I is for insulin, the P for potassium, the A for antibiotics. So you can either use the mnemonic FIPA or you can use the mnemonic CIPA. So if we're using the mnemonic FIPA, the first thing that we're going to be looking at is the fluids. So how exactly are we going to be calculating the fluids? I'm using our same practical example that we have of this child that is actually 25 kilograms and has come in with DKA. And remember that the assumption that we made of patients that actually come in with DKA is that they are severely dehydrated. And remember that with severe dehydration, you're losing greater than 10% of your body weight. And in addition to this 10% here sometimes is overestimated loss. So usually with the research and most of these review papers, they keep it at about 6.5% to about 8.5%. So if you're actually translating this into mils, this is going to be, of course, 100 mils per kg. Then, of course, this is going to be about 65 to about 85 mils per kg. So it means that for you now to calculate the deficit, how much this child has lost. So if we have our deficit over here, we're going to say the body weight of the child, we multiply that by the percentage loss. So the body weight of the child is going to be 25 kilograms. And then, of course, you multiply this by 100 if you're using 100. Of course, if this is in our setting, so it means that this will come up to about 2,500 mils. Then if you're using a lower threshold, especially with those that have malnutrition, in our setting, if we're using 65 mils, so if we're using the same example, but then this is using 65 mils and we multiply that by 25, you're going to be getting a deficit of 1,625 mils. But remember that this 2,500 mils must be given over 48 hours. So this must be corrected over 48 hours. The reason why we don't want to correct it over 24 hours is because they run the risk of actually having fluid overload. So we want to correct this deficit over 48 hours. So now how are we going to do this? We also need to calculate the maintenance fluid. So maintenance is another concept that many people actually know. Many people also do not know. We use a certain formula which is known as the Holiday-Serger formula. So of course this is for children or the young ones that are greater than 2 months. So if they are younger than 2 months, this formula does not apply. So we use 100 mils in the first 10 kg, 50 mils in the next 10 kg, 20 mils in the remaining 10 kg or remaining weight that is there. So if we get this 25 kg, we can actually divide this 25 kg into multiples of 10. We have the first 10, we have the second 10, meaning that 10 plus 10 is 20. 25 minus 20 is 5, so we remain with 5. So 10, 10, 5. So the first 100 mils, we multiply that by 10 kg. The next 50 mils, we multiply that by the next 10 kg, and the remaining 5, we multiply that by 20. So if we multiply this, this will give you 1,000. This is going to be giving you 500. This is going to be giving you 100. Okay, so once now you have calculated this, you have to add all of these together. So if we add 1,000 plus 500 plus 100, so this is going to give us a total of 1,600 mils. This is known as the maintenance. This covers for the insensible losses that a person actually incurs over the different days when, of course, you're going to be replacing the fluids in this child that has DKA. So remember that this is going to be our 1,600, but remember that this is going to be given in over 48 hours. So this also, you can either leave it like this in 24 hours because we're going to reduce the aliquots eventually, or you can add another 1,600 to this such that you can now calculate this 1,600 over 48 hours. So if you say 1,600 plus another 1,600, you're going to be getting a total of about 3,200. So this means that over 48 hours, this person must receive 3,200 of maintenance fluid. So now the total fluid that this person is going to be receiving is, of course, you're going to have your deficit that is going to be given. So you're going to be having this 2,500 mils multiplied by your maintenance, of course, in the 48 hours, which is going to be 3,200. Then, of course, this is the total fluid that you're going to be giving in 48 hours. So we'll call this T48. So if we actually do the math with this and we say 2,500 plus 3,200, it gives us a total of 5,700 mils in about 48 hours. So if we're giving 5,700 mils in 48 hours, how much are we going to be giving in 24 hours? So we can actually divide this by 2. So if we divide this value here by 2 to find out how much we're actually giving in 24 hours, it means we're going to be giving a total of 200 2,850 mils in 24 hours. So I just simply divided this value here by 2. So we further want to decrease this to give it 8 hourly. So if you want to give this 8 hourly, we're going to divide this by 3 aliquots. So if we divide this by 3 aliquots, that gives us roughly around 950 mils. So it means that this person is going to be receiving 950 mils 8 hourly. And that's the order that you're pretty much going to be giving your nurses, that this child must receive 950 mils over 8 hours. And remember that your fluid of choice in this case is pretty much going to be your normal saline, but once now your sugars are less than 12, we're going to be switching to DNS, dextrosaline, because we want to prevent hypoglycemia. So this is pretty much how we're going to be doing the fluid calculations. And remember that if a patient actually has hypernatremia, we want to actually use half strength normal saline, but of course you have to consult before you actually do your half strength normal saline. So I shall run through this calculation one more time. Remember, we have a child that is 25 kg, is with DKA, so the assumption is that they're severely dehydrated, and with severe dehydration we're losing more than 10% of the body weight, so that's about 100 mils per kg. So our body weight is pretty much going to be the weight of the child multiplied by 100 mils per kg. So it means that this person is losing 2,500 mils. But of course, this deficit must be corrected over 48 hours and not really 24 hours to prevent overhydration. So we want to also calculate the maintenance that we're going to be giving in the first 24 hours and the maintenance that we're going to be giving in the next 24 hours. So the Holiday-Seger formula, 100 mils for the first 10 kg, 50 mils for the next 10 kg, and 20 mils for the remainder. So this is going to give you 1,000. This will give you 500. This will give you 100. So it means that in 24 hours, this person must receive a maintenance of 1,600 mils. Then, of course, in another 24 hours, they should receive another 1,600 mils. So this makes 48 hours together. So this is going to be what they're receiving in 48 hours, which is a total of 3,200 mils. So it means that now to find the total fluids that they're going to receive over 48 hours, we're going to say this 2,500 plus this 3,000, which is of course your maintenance fluid, plus your deficit, it gives us 5,700. But of course, you're not going to be leaving these orders in the file because it's going to confuse a lot of people. So you want to divide it into small aliquots. So how are we going to divide this? If this is given in 48 hours, how much are we going to give in 24 hours? We can divide this number by 2. The 5,700, we can divide this by 2. So if we divide the 5,700 by 2, we get 2,850 mils that was supposed to give in 24 hours. Again, this is quite a lot to just leave as an order because you find the nurses have, or whoever is administering the fluid has given the 2,850 all at once and very quickly, and this child is actually edematous or actually may even be going into heart failure. So we want to give small portions over 8 hours. So we can actually divide this by 3. And then it will come up to 950 mils that we're going to be giving 8 hourly. Our fluid of choice is pretty much going to be our normal saline. But of course, once the sugar is less than 12, we're going to be switching to our DNS. And then of course, if we check the electrolytes and we find out that this person is hypernatremic, has a high concentration of sodium, we pretty much want to use half strength normal saline. But please make sure that you consult before you actually decide to use the half strength normal saline. And remember where we're coming from. So we had the fluids, we had the insulin, we had the potassium, we had the antibiotics. So we have taken care of the fluids. So the next thing that we're going to be looking at is the insulin. Now the insulin must be given as a continuous infusion. So here we're going to be using a dose of 0.1 units per kg per hour. If you have an infusion pump, this is very, very good for you to use. So we'll use our same example of a child that is 25 kg. So if we multiply this by 0.5 international units, so it means 25 multiplied by 0.1 international units, so that gives us about 2.5 international units per hour. So it means every hour this person must receive 2.5 international units of insulin. And once now your blood sugar has actually dropped to less than 12, you can actually half this dosage and give 0.05. So if we divide that by 0.05, if we divide 2.5 divided by 2, that's going to be giving us about 1.25 international units per hour. This is if this person's blood sugar now is less than 12, we're giving half the dosage to prevent them from tipping into hypoglycemia. Then you want to ensure that your blood sugar is falling at a rate of about 5 millimoles per liter. So it should be less than this, and it shouldn't exceed 5 millimoles per liter. If it's falling faster than this, meaning if your previous reading was 25, your next reading an hour later must be between 20 to 25. If it's greater than this, it means that your sugars are moving too fast and you must slow down the rate at which you are giving your insulin, or at least you're not really rehydrating the patient quite well, and there's a risk of them tipping into hypoglycemia. Then the next thing that we're going to be giving is, of course, our potassium. In this case, we want to make sure that we have some ECG monitoring, and once you have the ECG monitoring, what you're going to be looking out for on the ECG is, of course, our peaked T waves. So once you have the peaked T waves on the ECG, and of course you have a potassium concentration that is, or a person that is hyperkalemic, a potassium serum concentration greater than 7 millimoles to be exact, it means that this person has the hyperkalemia. So we want to prevent this. So remember that to prevent this hyperkalemia, we must ensure that this person is passing urine. They are not anuric. So it means you should catheterize your patient. And then if you check now the levels of the potassium, and you find out that this person has hyperkalemia, okay? And remember that the normal concentration of potassium is roughly about the 3.5 to about 5.5. So if it's greater than the normal, if there is hyperkalemia, we do not give potassium. So there's no potassium chloride that we're going to be giving. If it's within the normal range of the potassium, we're going to be giving about 20 millimoles of potassium chloride. Now, remember that this must be given usually in the second liter of, or the second bag of the IV fluids, and make sure that this patient is actually passing urine. So it must actually be given with every 500 mils of fluid that you actually give after you have given the first fluid. Then, of course, this must be given for the first 24 hours. So this must be given for the first 24 hours. Same thing if the patient is actually hypokalemic, you can actually even give 40 millimoles of potassium chloride, but you must, of course, be able to manage this person and look at their potassium concentration, make sure they're passing urine, and connect them to an ECG machine. The other thing that we also look for is, of course, we search for any infection. So we want to take some cultures that we're going to be sending to the lab. We want to take a urinalysis. You want to take urine culture, microscopy sensitivity. You want to look for a focus of infection so that you can cover this patient on broad spectrum antibiotics. And these antibiotics generally depend on your sensitivity patterns and where you are in your patient management is according to your antibiotic protocol in the hospital. Some common antibiotics that we often put our patients on include the third generation cephalosporins. So we can use drugs like ceftriaxone, we can use drugs like your cefotaxime. Then we can also use penicillins, though some people do not have so much faith in the penicillins, such as your Expen and of course your combination with gentamicin. But of course with gentamicin there is a risk of renal injury because of this patient is being dehydrated, so we want to use that with caution. So that's why we usually normally stick with our third generation cephalosporins. So that's pretty much an overview and a summary of DKA in children and the management of DKA in children. If you did enjoy these lectures and you really want more of such lectures where we teach you on a whiteboard or a blackboard in our case, please hit the subscribe button, hit the bell notification icon, and comment in the comment section below. It shows a big growth improvement of the channel, and I want to thank each and every one of you for helping me reach 5,000. What am I saying? 1,000. 5,000 subscribers. We are almost halfway there to 10,000 subscribers. Keep subscribing to the channel, hit the bell notification icon. Till next time, my name is Dr. Moses Kazevu. Bye bye.